good evening, everyone, and I want to welcome you to the CSF lecture series. I mean, it's all old friends here now, which is great. A couple of new faces. Just a couple of things. This year, we have on our calendar that on June 24th and 25th, we're going to do a half day of lectures at the Bethesda North Marriott. And we're calling it like a coalition collaboration. So the idea is to have comorbid disorders as well as people with Chiari, Syringomyelia all come together, and we're going to have a few lectures for educational purposes, but we're also inviting the PCORI group to come over. So PCORI stands for Patient-Centered Research Outcomes Institutes, and it's a group that is funded from the Affordable Care Act. It was money that was put aside. And the idea behind it is that you have patients involved in research from the beginning, not as an afterthought. So whenever any of these studies or projects go on, basically it's the patient's questions that are being answered, and then the researchers come to help answer those questions. So it's really taken off. It's done good things. Because it was funded under the Affordable Care Act, the question is, will the funding continue? So one of the thoughts was that all the groups who are involved in this could come together and have our meeting, learn exactly what's going on, and get some common points that we can take up to Capitol Hill the next day and advocate for more funding for patient research. So it's a goal that we can all do together, and we're hoping if you're interested, go to the csfinfo.org and learn more, or call our office and learn more. We'd like to have, our goal is to have at least 125 people this year. So if you feel like it's something you would like to do, to reach out to your representatives and let them know how important research in these areas is, then please become part of it. Everyone kind of knows me, Dorothy Poppy, but we don't always have the opportunity to meet some of our board members. So I wanted to introduce Kim Dawson, who is on our board. He's going to come up, which this is unique. He's from Orlando, and it's an interesting history we have. So I'm going to kind of let Kim tell you about why he's here, how he got involved, all that.
I'm a fish out of water amongst all of you medical folks. I'm a film producer, and I met Dorothy on the set of the Bobby Jones film that we made in Atlanta about 13 years ago, I guess. And I got involved. I knew enough about Jones to know that he had suffered from the disease, but didn't know the connection to, at that point, ASAP, and now it's Dorothy left there and formed CSF to really move the awareness of the disease forward in a way that I don't think had ever been done before. I'm very proud to be part of the group. I've worked with Bob Jones IV for a number of years, and I think the family has embraced the idea that Jones could be a great spokesperson and posthumously for finding a cure for the disease. So I'm thrilled to be part of the organization, and I've had the honor to meet Dr. Henderson over the phone in the past when my daughter suffered a thing that he was very helpful with a diagnosis on, and I'm very appreciative for that and for the insights that you guys all have for attacking this disease in a way that will ultimately lead to a cure. So I'm honored to be here, and thank you very much.
So we do have I call it an eclectic board, but I love it because the point is we're trying to bring people from different arenas together to get a message across. And Kim is working with us right now on putting together a social media message for golf, and there's a lot of money in golf, and we can probably raise a lot of research funds in golf. So he's going to try and get that message out with Matt. Where is Matt? Matt's our videographer, and with the team we have, I think we can really do it. So if you do have any questions ever, please, feel free to reach out. I don't know whether to let Fraser. Why don't you come up? Dr. Henderson, come up, because there are some other great people in the room who are here, and geez, I can go from table to table. But I'm going to introduce. So Dr. Mark Luciano, who's the chairman right now of our scientific board, is in the back from Hopkins. So thank you, Mark, for coming, and I'm going to let you take it away from here.
Great. Thanks, Dorothy, and thank you all for braving the cold weather and coming today. We have some very intrepid patients and also some of the finest doctors in the East Coast right here tonight. Let me just welcome J.R. Buckland. And
this is Renee.
Renee, okay. And my new colleague, Robert Rosenbaum, who's an extraordinary neurosurgeon who's taken a big interest in Ehlers-Danlos syndrome and was dealing with a lot of these patients in the Navy in his, while he was there. He was at Penn State before that. I'd like to welcome Dr. Alphabaum, ophthalmologist, Dr. Williams, and Dr. Pavel Klein, neurologist, who's spoken to us on seizures, various seizure disorders and sleep problems, and has done a lot of research on brain cancer and many broad things. Dr. Mustafa Sharma, MD, PhD, and thank you for being here tonight. My OR crew are all there tonight. Dr. Sarah Merritt, anesthesiologist from Johns Hopkins, Claudius Austin, internist extraordinaire, and Peter Rowe, professor at Hopkins in internal medicine. Mark Luciano is one of the world experts on hydrocephalus and runs the CSF disorders at Johns Hopkins. And we're fortunate to have Dr. Aruna Rao to speak tonight. She's I'll introduce you momentarily. And Miles Kobe, with whom you're all well aware, who makes these amazing diagnoses. Claire Francomano needs no introduction. And Kevin Lasko, who is new to our group, who's been doing great work with diagnosing hypermobile disorders of the craniocervical junction and cervical spine. So thank you all for being here tonight. Could I introduce Aruna Rao, who is assistant professor of neurology at Johns Hopkins, and we're very pleased to have you here tonight to talk about headaches. And if you'd come down, Arun, and then Dr. Luciano will be talking, and I also have a presentation. If you can last that long. Okay, so I think that's your talk. Yeah. And, okay, about 20 minutes. Okay. Yeah, great.
All right. Hello, everyone. Thank you so much for inviting me to do this. Headaches are a huge topic, and I'm going to try my best to get this done in the time allotted. Trust? Okay. So I'm going to be talking about headaches, but with a focus on dysautonomia and EDS, which, again, the general principles are that you have to diagnose the headache and treat it as any other headache, but keep in mind some of the features that are more common to this population. I have no disclosures. So I want you to look at this picture, and if it makes you gasp, then it's important to identify the type of fin that you see, triangular versus curved. And now when you look back at the picture, you see that it's a curved fin, so therefore dolphin, and probably not scary. So in headache management, it's really important to identify the dolphins versus the sharks of headaches. Primary headaches are the dolphin headaches, so no underlying cause, very common and can be unpleasant, but are usually not dangerous. The sharks are the secondary headaches. They are a sign, a warning sign that your brain and head and neck area is giving you that something else is going on. So these are the ones that we really do not want to miss before we diagnose a primary headache. A primary headache is a syndrome, usually neurochemical factors associated that cause the headache, but in secondary headaches, it is a symptom of a more sinister problem. I'm going to touch briefly on the pathophysiology. I don't want to bore you with this slide, but essentially the trigeminal nerve, which innervates the entire head and neck area, the blood vessels, the meninges, all the soft tissues in and around the head and neck area, innervated all the way up to the cervical spine, are innervated by the trigeminal nerve. These fibers are very sensitive. They then meet here at the trigeminal ganglion. This then goes and meets here in the trigeminal cervical complex, which then passes fibers up to the thalamus, which is where all the pain in your brain is felt. There are many chemicals involved. Serotonin is primarily the chemical that we target when we use medications, but there are lots of other novel targets that are in the works, CGRP being a very exciting one that we're still waiting for. But all of these other chemicals are involved in producing pain in the head and neck area. The trigeminal nerve, as you can see, has far-reaching areas of involvement, and like I said, all the way down to the second cervical vertebrae. Primary headaches are typically the usual headaches that you hear about: migraines, tension headaches, cluster headaches, all of these headaches on the left. I'm going to be talking about migraines and tension headaches, which are more commonly associated in our specific population, but if you ever wanted to hear about or learn about some of the other headaches, the International Classification of Headache Disorders is a great area if you're not sure about what type of headache you have to look at to identify some of the other more less common headaches. Secondary headaches, like I said, could come from anywhere in the head and neck area. It could be blood vessels, it could be cerebrospinal fluid pressure, either high or low, structural problems, a brain tumor or other cysts, bleeding in the head and neck area. Cranial neuralgia is any inflammation of the nerves, any infections, medications, either side effects of the medication or withdrawal symptoms, and there are some genetic syndromes that are associated with headaches as well. So again, secondary headache warning symptom. Important to pay attention. So in EDS and dysautonomia, like I said, it's similar to how you would diagnose any other headache. You have to do a thorough history and a physical exam, screen for dysautonomia, which we always do when we see headache patients in the clinic, screen for EDS. If there's a suspicion, certainly order the right tests to so that we can send patients on the right path, because the treatment sometimes could be one medication that treats both conditions, so it's very important to not miss this. And then you treat based on the headache type. So episodic migraine, like I said, chronic migraine, menstrual migraines are also very common in the specific population, tension type headaches and chronic tension headaches, which I'll talk about. Again, headache is a huge topic. I really tried to trim it down as much as I could, so we'll stick to these for now, but it should be sufficient, I think, to cover most of the common problems that we see in our clinic. Now, it's very important in EDS to not forget that connective tissue problems, so neck problems can cause headaches. Again, feeds right back into the headache center, temporomandibular joint issues, and then other disorders, homeostasis, sleep disorders. Sleep disruption is very common cause of headaches in general, but specifically in the EDS population. Poor food intake because of just a general malaise, not feeling well, and then orthostatic intolerance. Intracranial hypertension and CSF leak are causes of headaches, which I will not be covering because this is a big topic in itself, and Dr. Luciano and Dr. Henderson will be talking about this. Red flags. When should you worry about a headache? When should you go to the emergency room or seek immediate help? If your headache is thunderclap, time to peak is less than 5 minutes. Any host factor, so anyone over 50, we're always a little worried. New headache, never had a headache before, now suddenly has a headache. Any immunosuppression, new neurologic symptoms, new neurologic signs, changes in exam, changes in cognition, thinking, personality, behavioral changes, and of course fever, neck stiffness, any headache that changes with posture, visual changes, and if there's any history of vascular problems, so blood aneurysms or arteriovenous malformations. So headache pattern is important when you go to the a clinic or the emergency room. People want to know, what type of headache do you have? Is it just acute recurring? Which is the most of the primary headaches follow this pattern. They just happen and then you treat them and then they go away, they come and go, versus just the acute headache, which is more than likely a secondary headache, right? This is the headache you worry about. No history of headache, suddenly have a headache. Then the next kind of headache is the chronic but progressive. It's chronic headache, but it's getting worse. Also, you might want to think about a secondary headache, and then you just have the headache that just doesn't go away. Most often there is a physical cause, of like a neck problem or a TMJ problem or some other physical cause of the headache. And then you have the new daily persistent headache that just starts one day and stays severe. Could also be a secondary headache. All of these headaches could be secondary headaches. Now, as a rule, examine everyone. Sometimes we'll see doctors in the clinic and they're like, oh, I've already done my exam, it's completely normal. I always re-examine respectfully, and you'll be surprised how many abnormal exams you'll find. So check everything. Definitely do a fundoscopic exam. We check the neck for point tenderness, paraspinal muscle tenderness, trigger points. These are all treated differently, right? If there are neck problems, then you want to treat that specifically. It could still present as a headache, but the primary problem, our job is to identify the primary cause of the headaches. Temporomandibular joints, blood vessels, look for any abnormal flow, because you can hear this breathe if you listen over specific areas. Always feel for the cranial nerve. Sometimes it could just be a cranial nerve that's inflamed. That could be presenting as a migraine. Pericranial muscles are all these headache-specific muscles, and the frontal, the side of your head, and the back. And these can be tender, especially in tension headaches. And the sinuses, we always, I'm not talking about the venous sinuses, but the actual sinuses that you can have infections that present as chronic headaches. Brain scans, not always necessary. The American Headache Society does not recommend it if your exam is normal and if you're confident that it's a primary headache. And you must be you worry because you find things and then now you're anxious about these things. And now lots of people have white fluffy things, and lots of migraineurs have white fluffy things on their MRI, which we call hyperintensities, and they're quite normal. We call them unidentified bright objects. And it happens. It doesn't mean you have MS or a brain tumor. It occurs because there is some abnormality in the blood vessels in patients with migraines. But harmless, nothing to worry about. Blood vessel imaging is very important if you're worried about high pressure headaches, if someone has headaches that change with position, or if you're worried about any secondary headaches, then you do get blood vessel imaging. These are images of venous sinuses, but we also often image the arteries. Always image with contrast, and a CT angiogram has a little bit better resolution than an MR angiogram or venogram. CT scan for sinus infections. As you can see here, the maxillary sinuses are infected, and there's a sinus in the back of your head called the sphenoid sinus, which very often is a cause of chronic headache. So you're just being treated all the time, headache doesn't get better, look for other causes that you could be missing. MRI of the neck, of course, big cause of headache. Like I said, up to the second cervical vertebrae still feeds back into the headache center. So you could be presenting with a migraine every day, but this is the cause. So again, headache classification, very clear, very easy to understand, very formulaic, no guesswork involved. The American Headache Society has the International Headache Classification very clearly listed. So migraines can happen with or without aura, which we'll talk about. There are other more specific type of migraines called the basilar migraine and hemiplegic migraine, which I'll talk to you about as well. Medication overuse headache, tension headaches, and this we'll have to leave for another day. So migraines are very common cause of morbidity and disability in our population. Women have more prevalence than men after puberty, and then the levels drop off after menopause. Children have migraines as well, equal before girls attain menarche, and then girls have more migraines. So essentially hormonally driven is what this slide is trying to tell us. Again, like I said, very easy to diagnose. Just read the criteria. 5 attacks lasting 4 to 72 hours, unilateral, moderate or severe, aggravated by routine activity, and pulsating or throbbing. So people come up with all sorts of mnemonics for it. So you map it. This is one of my colleagues' favorite mnemonics, so I decided to use this. But the time course is very important. Associated features are important: nausea and vomiting, photophobia, sensitivity to light, phonophobia, sensitivity to sound. So you have to have either they're very purist about this, either nausea or vomiting, but you have to have sensitivity to light and sound. Now, if you don't have all of these criteria, it could be a probable migraine or a possible migraine. But like I said, headache doctors are purist about this criteria. The associated symptoms: sensitivity to light, sensitivity to sound, nausea and vomiting, sensitivity to smell, and aura. Now, aura can be like the picture here on the left, flashes of light, zigzag lines, or it could be negative phenomenon like this, just sudden loss of vision, tunnel vision. Now, as you can see, there are lots of similarities to the visual symptoms that occur with dysautonomia. So very often, you can have patients presenting with similar symptoms, and you have to be able to differentiate which one. If you treat it as a migraine and miss the other signs of dysautonomia or not address those, the patient is not going to get better. Headache phase is also very important. There's a prodrome phase, there's a headache phase, and then there's the post-headache phase. Also, a lot of similar symptoms in dysautonomia and in patients with EDS, where the prodrome is a lot of malaise, fatigue. Patients describe so many different types of symptoms. Brain fog is very commonly described either prodromally or postdrome after the headache. So it's very important to ask for those symptoms and make sure that it is part of a migraine before you assume that it is. Now, hydration and other treatments are part of migraine treatments as well. But I think that it's important to make sure we screen appropriately for the right diagnosis. So these are some of the symptoms that are similar in the prodrome of migraine and dysautonomia, as well as the postdrome. Dizziness very commonly seen in basilar migraines, and also you can also have positional symptoms with migraines, and that can be confusing for the diagnostician. So I'm just going to talk about the basilar and hemiplegic migraine first before I go to chronic migraine. Basilar migraine is when you have all the symptoms associated with the back of your brain. So double vision, incoordination, trouble with swallowing, trouble with your speech, trouble with your vision, dizziness. Hemiplegic migraine is when you actually have weakness. Typically with the migraine aura, you never have weakness. You can have sensory loss, you can have visual loss, you can have speech problems, which all should go away within an hour. And you should never have weakness. If you do have weakness, then more than likely, and it's not from a stroke or other neurologic cause, then you suspect a hemiplegic migraine, which is a genetic condition, and you cannot use the traditional migraine treatments for these two types of headaches. So no triptans, which I'll talk about in these two headaches. Chronic migraine is if your headache lasts 15 days or more per month for 3 months. So triggers are very important. Alcohol, for some people, caffeine, or caffeine withdrawal, certain foods, hunger, people skip meals, dehydration, very common, very common. People often will ask me, why can't I just drink coffee? It's made with water. But your coffee contains caffeine, which is a diuretic, therefore dehydrating. It's very difficult to make people understand how important water is for multiple conditions. Glaring, flickering lights, smells for some people, changes in sleep patterns, and then hormones specifically for, and weather changes. The weather changes are important because the trigeminal nerve has receptors, baroreceptors, not clearly identified in humans yet, but very clearly described in animals. And altitude as well, due to the changes in your oxygenation and carbon dioxide levels. So they can be aggravators, or they could be actually triggering your headache. So very important to identify these and treat them, because if you don't treat them, your headaches are not going to get better. Treatment is usually divided into acute treatment, what you use when you have a headache, preventative treatment, medication that you use every day, and then there are lots of physical treatments as well, and non-medication options. So usually non-steroidals, triptans, which are the very specific for migraines. Ergotamines are older versions. Dihydroergotamine is something that we use very frequently now. Narcotics are never indicated for headaches. Anything with butalbital, Furoset, Furanol, never indicated for headaches. American Headache Society does not recommend it at all, because it can cause a medication overuse headache, rebound headache, and the treatment, if you do have a rebound headache, a medication overuse headache, is stopping everything. So I think it's better not to start unless you can limit it to 2 times a week. So the treatment model is to treat early, treat in the early stage of that headache curve that I showed you. Use combinations. We often will use a non-steroidal with an antiemetic, with or without diphenhydramine or Benadryl, to help with some of the side effects of this, and also to help with sleep. Avoiding the emergency room is very important, but if you do get to the emergency room, we will use cocktails of medication with no alcohol, and no narcotics, magnesium with IV fluids, ketorolac, Benadryl, diphenhydramine, and antiemetic in combination intravenously, often helps break the headache cycle. And this often you will use once you've already tried your oral medications at home, and if they haven't been working or your headache is going into day 2. You can use steroids, you can use dihydroergotamine, always given either in the emergency room or in an infusion center in a monitored setting. Reglan or metoclopramide, which is an antiemetic, and occasionally we'll have to keep upping the ante every 30 minutes. If this for basic cocktail does not work, you add the steroid. If that doesn't work, go with DHE. If that doesn't work, do metoclopramide. If that doesn't work, you do the valproic acid. And by that point, usually the headache has remitted, or you may have to admit them for inpatient pain management, where dihydroergotamine is the treatment of choice. You use it 3 times a day for about 3 to 5 days, again with the nausea medications, with or without steroids, and then other treatments as needed, nerve blocks, other pain management treatments as needed. A lot of times we use inpatient headache management to break the cycle of medication overuse headaches, which, like I said, is one of the biggest challenges for any headache practice. Again, when would you use a preventative? If your headaches are bad enough that you want to take a medication every day, if there is another condition that you can treat with the same medications, and as you'll see, the medications are so many choices, and they often treat other conditions concurrently. So antihypertensive, so beta blockers, very, very effective, even propranolol, one of the oldest headache medicines, but works excellent for headaches and medication overuse headaches. A lot of the blood pressure, other blood pressure medications, antidepressants, SSRIs, SNRIs. The tricyclics and the SNRIs are a little bit better for headaches. Anticonvulsants are very good for headaches, and all of the antihistamines mostly we use in children. Food supplements like vitamin B2, magnesium, and coenzyme Q10 have good evidence. Feverfew and Butterbur not used anymore due to recent evidence of liver problems with the Petadolex or Butterbur, and Feverfew has not been as effective. So these are the FDA-approved medications, but as you can see, the choices are many, and they do multiple functions. So it's you could choose the medication based on other comorbid conditions, and then also use this chart as a guide to avoid medications in certain populations as well. Menstrual migraines happen because the estrogen levels drop suddenly. So the mainstay of treatment is to, one, treat with an abortive treatment for 2 days before the period and 2 days following the beginning of the period. So you patients will be on either non-steroidal or a triptan medication, which is specific for migraines, for 4 or 5 days. It's very important to be able to predict the cycles to do this. Otherwise, you have all the medications that use the oral contraceptives. The idea is to make sure the estrogen does not plummet, that the estrogen levels either stay steady with low estrogen or oral contraceptives, or use progestin-only contraceptives. So sometimes patients are desperate and will try androgens or induce chemical menopause, but this is rare, and if their headaches are very, very severe and disabling. Transformation of headaches, I can't tell you how important this is. Preventing an episodic migraine from becoming a chronic daily headache is very important, because it's very hard to treat once it becomes chronic. The patient suffers greatly because we take away all the daily nonsteroidals. That is the mainstay of treatment. Most headaches remit after you've stopped all the medications for 6 to 8 weeks. But going through those 6 to 8 weeks is very, very painful for the patient. It's really hard to understand what causes it. These are the train wrecks that happen that come to our office, and it is very difficult to see because it's really been misguided treatment and sort of unregulated treatment on our part. I think on the treater's part, we have monitored closely how much medication the patient is taking. So headache for more than 15 days a month. If you take for pain medication, any abortive therapy, for more than 10 days a month for 3 months, you're likely to develop a medication overuse headache. It typically presents as early morning headaches. There are 2 other headaches that present as early morning headaches. One is a sleep apnea headache, and one is a cervicogenic headache, or headache coming from your neck. Typically reverts after you stop the medication, but that's the hardest part. Tylenol, acetaminophen, and nonsteroidals are the most commonly used medication that causes this, but triptans, butalbital containing agents, and narcotics follow shortly. But overall, the good news, again, I don't have any data past 2005, but the good news is that the prescriptions have decreased, and that the incidence of this headache is decreasing due to more education. Tension headaches are anything that a migraine is not, Bilateral, both sides, pressing, tightening, vice-like grip, not aggravated by physical activity, no other features, but they can have either sensitivity to light or sound. Very difficult to treat acute tension headache, but chronic tension headache is responds to antidepressants. But I'll give you a whole bunch of physical symptom treatments that we use for tension headaches. So this is what pericranial muscles are involved. It's muscle tightness, muscle tension, and muscle pain in these specific areas. So like I said, triptans, none of the acute treatments are helpful, but amitriptyline is a good option for tension headache. Non-pharmacologic treatments in general, physical treatments, heat packs, ice packs, exercises to strengthen and stretch the muscles. Change in posture sometimes helps. Changing your pillow, changing your mattress. These are things that can help with your headaches if that's the primary cause. We sometimes will recommend yoga, tai chi, progressive muscle relaxation, breathing techniques. Biofeedback is very, very good. Excellent grade A evidence for headaches as a standalone treatment or with other preventative treatments. Acupuncture is okay when added to other medications. We usually will use it for patients who have insomnia or anxiety or other treatments or other conditions that are treated primarily by acupuncture. Changes in diet, it's a very personal thing. Lots of people say red wine makes their headaches worse, or aged cheeses, and MSG, because this contains glutamate, which is an irritant in your central nervous system. However, it's a personal thing. I usually tell people to identify foods that they think may be triggering their migraines, do an elimination diet for 2 weeks, and then reintroduce it and see if you are right or not. Some of these elimination diets that are prescribed can be quite restrictive, and it's not one size fits all. So a food that might be triggering for one patient may not be for the other. Cognitive behavioral therapy, very, very helpful. Again, either good as standalone, but much better when combined with medication. And psychotherapy for some patients who just have anxiety and depression, which is very, very comorbid with headaches. With migraine headaches specifically, depression has a bidirectional relationship, and anxiety has a unidirectional relationship with migraine headaches. Lots of nerve blocks and surgeries and things that we could do. So, we do a lot of nerve blocks. We do a lot of nerve blocks in the clinic, but you have to identify the exact nerve that's irritated. Also, it's very important to make sure that the skull is intact. If they've had a decompression or something and they have part of their skull missing, always make sure that we examine for their occipital bone. But very easy to treat, high yield, diagnostic and therapeutic. You know you've made the right diagnosis and the patient feels better immediately. Supraorbital, supratrochlear blocks, also quite easy to do without any imaging, but auriculotemporal, any of the other blocks are a little bit more complicated and preferably done under imaging. Sphenopalatine ganglion blocks are really not even a block. It's just a tiny tube that goes into your nose and injects the lidocaine directly into the sphenopalatine ganglion, which is right here in your cheek. There are some surgeries that can help with headaches. I think for this purpose of this talk, just radiofrequency ablation for occipital nerve problems are quite an effective treatment, but the nerves usually do grow back. Botox, again, very effective. You have to have, you have to look at the dog. I mean, not everyone has this dramatic change, but changes, if you treating the wrinkles also feeds right back into the headache center. So that, and also treating, desensitizing all the headache-specific nerves, headache-specific muscles, that was what you're targeting with Botox. There's one protocol, the Preempt protocol, is the only protocol that's FDA approved. A lot of times patients will come and say they've tried Botox and they think they've failed it, but they have not had the right protocol. The protocol includes injecting here in the forehead, in the middle here, 4 on the top of your forehead, 4 on either side of your head, 3 on the back of your head, paraspinals, and your shoulders. So if you haven't gotten that treatment, that you haven't had true Botox treatment for headaches and you've not failed it yet. Occipital nerve blocks, like I said, very easy to do in the office, and very high yield if it is the cause of your headaches. And you don't need to take medications if it is occipital neuralgia. I mean, you could be pumping yourself with medication while the problem is something more superficial and might be more easily treated with targeted injections. Occipital nerve stimulators, we do not recommend this. You can see that the lead here is really long, and sorry, I can't find it. Okay, and it goes all the way down here, and this is where the generator is. By the time it reaches here, it has fractured, it bleeds, it's very complicated to manage. A lot of times we're having them taken out. Vagus nerve stimulators works better for seizures than it does for headaches, but if someone has seizures and headaches, it might be a good option. Same for external vagus nerve stimulators, not as effective for migraines or other headaches. Hypothalamic deep brain stimulation, again, not great evidence. For migraines, there's no evidence. For cluster headaches, maybe, but only if you failed every other treatment. Sphenopalatine Ganglion stimulators are on the market now, but these are not great for migraines. Maybe used for intractable, uncontrollable migraines because of that feedback loop, like I showed you, that goes right back to the headache center from any of the trigeminal nerve endings. It's like a cell phone device. You can turn the stimulator on and off. If you've had a sphenopalatine ganglion block in the office and it has worked for you, you might want to consider this as an option. But if it hasn't, then don't go for any implants that are not going to work. But much more useful in cluster headaches than in migraine headaches. There are lots of other treatments that you can try for migraine headaches. The supraorbital device is brilliant. Whoever came up with this, someone in Europe, where all great ideas come from, sadly. Stimulates the supraorbital nerves. Great device, FDA approved, sadly not covered by insurance. Costs about $350. You do need a prescription for it. Very portable. And it's 20 minutes every day. You can use it as a preventative. You can use it as abortive therapy. Again, this is what it looks like on Dr. Rosenberg, previous director of our headache center. But those two prongs can be problematic. So they came up with Cefaly 2, where you can actually lie down. It kind of lulls you to sleep. It's a very effective device if it is the one that's going to work for you. Again, it's about targeting the treatment for the right patient. They do have some attachments that you can put it on occipital nerves if you need to. But for the occipital neuralgia and headaches in general, transcranial magnetic stimulation, which is this new eNeura device, which is not yet in the market, but we are starting to use them. They're not available by prescription yet, but you can. It's certainly going to be out very, very soon. Portable transcranial magnetic stimulation is very effective for headaches as well as for depression, so it might be a treatment that you can combine in certain patients. And that's all I have for you. These are some useful websites. And I don't know if there's time for questions, but no questions. Okay, perfect. Oh, yes.
Distribution of headaches for your tension headaches was very similar to that shown for temporomandibular joint syndrome.
Yes.
Is there a lot of overlap there? Or?
So if you have pericranial muscle tenderness and it's more here in the temporalis muscle, then yes, we have to rule out TMJ problems. I think that with the tension type headaches, it can be all, and it is very similar. It's true. I think it's the posterior headaches that you may not have with TMJ. The neck and the trapezius soreness. Yes.
I had a question about whether you had any special tricks for the people who get headaches with weather fronts coming through? I find them to be the most challenging in my practice.
It's really difficult to predict when they're going to have. I mean, the best we could do is have them on a preventative that prevents them from getting them, or if they know for sure if they are in the early headache phase, just treat it with an abortive. But I think prevention and making sure that all their other lifestyle measures are being well controlled is the only way. I mean, you're right, it is very difficult because we can't treat someone's headache every time there's a storm. So I think prevention in those cases.
Thanks. That was the most comprehensive talk I've ever seen on headaches. Dr. Rao, thank you.